In this episode of the ASC Podcast with John Goehle, we discuss the latest news in the industry, including the nurses' strike in New York City. We look back on major ASC events in 2025, and in our focus segment, we'll discuss the activities that need to be done as you begin the year, especially focusing on governing body activities.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. We would like to thank our sponsors, Surgical Information Systems, providing cutting-edge information solutions for surgery providers, RFX Solutions, your all-in-one healthcare regulatory compliance software, MedServe, which is the only digital narcotic cabinet specifically designed and priced for surgery centers, helping standardize processes, compliance, eliminate paper logs and prevent drug diversion, and Ambulatory Healthcare Strategies, the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, please visit our website at ascpodcast.com.
Welcome to episode 266 of the ASC Podcast with John Goehle, recorded on January 13th, 2026, from our studios in Spencerport, New York. I'm Sue Cronkite, your co-host and operations manager at Ambulatory Healthcare Strategies. As a reminder, the regulatory landscape for ASCs is constantly changing. The content in this episode reflects the most current information available at the time of recording. We encourage all ASCs to remain vigilant and to keep up with any updates or new guidelines released by their relevant regulatory authorities. Joining me today is John Goehle, owner of Ambulatory Healthcare Strategies and one of the leading experts in the ambulatory surgery field. With over 3 decades of experience, John has authored more than 10 books on the ASC industry, and he is a highly regarded speaker on topics related to regulation, accreditation, and finance management.
So we wish everybody a happy new year. Hopefully everybody has started off the new year with a bang and everything's going well. It's been quite an adventure in our house over the last week and a half, hasn't it? My daughter and her husband and 2 children, my grandchildren, and their dog moved in when their furnace gave out in the middle of the nice harsh winters here in Rochester, New York. So
yeah, I think it was 20 degrees out or something. They really had no choice.
Yeah, and it was like 50 degrees in the house, so lower than that, I think, at some point. So it was great having the grandchildren and the children here with us, but they certainly were not very happy being away from home during that time frame. So we haven't been able to get an episode out until today, and here we are recording. We always promise, Sue, that we're never going to record after 3 o'clock because our voices tend to go down a little bit by that point. But so we're going to have a great episode. We're going to talk about kind of a retrospective on 2025 and also looking forward to 2026. One thing that we have noted, I think 2 of our facilities, we have about 87 facilities across the country, and 2 of them have had flooding incidents. One from a fire that resulted in the sprinklers going off, and another one just built up water coming in. And I know, Sue, I think we've mentioned this before a couple times in previous episodes here. So again, I just wanted to remind people that you don't have to be in a flood district to worry about floods. And just a reminder to make sure you address flooding in your policy manual. Make sure you've identified a disaster mitigation firm as part of that emergency plan, and then update that information regularly, because in both of these circumstances, it took extra time to find the proper mitigation firm because that information hadn't been updated. And one thing to remember as you're recovering from a fire, most likely you're also going to be recovering from a flood too. if you're in a sprinklered building. So when you have a fire, or a flood, make sure that your disaster plan is implemented right away. And this is a good one to test periodically or do a drill on so that you know what to do and how to handle it.
Yeah, as you said, you have to address it quickly because anytime you have a wet area, that is going to go bad very quickly. You'll end up with mold or, really soaked in deeper. So, you want to have all of that information at your fingertips or if it ever happens.
Yeah, and actually we had a drop-in session for you might remember, we've mentioned people, and many of you are patron members. For our patron members, we have regular drop-in sessions. We had one on Monday, yesterday, where we actually talked about this for a while, and one of the attendees actually had a fire, I think it was almost 8 years ago, something like that, which caused them to be out of business for almost 3 months. And the damage was not fire-related, it was all water-related, and they actually had significant problems with mold and mildew afterwards. And then another situation, we have another center that had a roof leak that resulted in some unknown or unidentified water damage to the floor. And then a couple months after all the mitigation had been done, they noted that one of the tiles was coming up. And it wasn't, it didn't have tile in the surgical area, but in the support areas, one of the tiles was coming up. They lifted it up and there was black mold underneath it. So take this stuff seriously. As soon as you have any water damage, you're probably going to have to, or most likely you're going to have to bring somebody in order to do some mold evaluation, determine if you have any mold or mildew. So let's take a look back on 2025 as we begin 2026. And Sue, we have been doing this since 2018 is our first episode. It was in January 2018. So we're celebrating our 8th year here doing this. Hard to believe. Of course, you've only been with me for a mere 6 years, but it has been quite a run. So as we begin our 8th year here, I thought I would kind of look back on what's going on and what happened in 2025 that had an impact. It wasn't a bad year for federal regulations. There weren't a lot of changes in the ASC world with regard to regulations, at least at a federal level. And the final 2026 payment rule did have some nice surprises for a change, as we've discussed in some past episodes. So a few of the key takeaways from the new payment rule was certainly one of the most anticipated, the removal of the NHSN reporting requirements for COVID-19. I don't think anybody is sad to see that one go. And of course, that was one of those requirements that had to be done every quarter, which was very burdensome. And then we also had in 2025 the health equity reporting requirements. It was just the beginning of what was going to be a multi-year implementation of health equity implementation or health equity reporting. That was found to be quite burdensome, and the administration did eliminate that requirement for 2026 and on. So not only are the health equity reporting that we had in 2025 gone, but also the ones that they are proposing for the future.
Yep, and like we had said before, it's a worthwhile information to gather.
Yeah,
but we're not in the right setting to address it and really be able to help people with any of those issues. Yeah,
and to your point, in case people were not aware, health equity reporting was requiring us to ask our patients whether they had any problem accessing enough food, health care, whether they were living in a safe environment, things like that. And again, I totally understand how that is a good question for a primary care physician to be asking, and I have no problem with it being implemented in that setting.
Even in an emergency room, part of the hospital, you've got all of those resources.
And that's the point, is that you have those resources available. In a surgery setting, this is an elective procedure. Most of them are elective procedures. And we just don't have the resources and certainly the time to do that. So we were always having a struggle trying to figure out how we were going to implement it in the ASC setting, and the elimination definitely is making it better. And then in the proposed rule in July, the administration had proposed a new survey called the Patient Understanding of Key Information Related to Recovery. It was called Pro-PM. The title itself was confusing and long enough. And the ASCA really fought this, and I did address this issue a couple times on the episode, including with some interviews with people from ASCA. And we were very concerned about this because it would have been another survey, and we were having a hard time figuring out how we would implement this in cooperation with OAS CAPS, since OAS CAPS doesn't allow you to do other surveys. So the administration in the final rule did remove that requirement, or did remove that. Now, they removed it for this year. There's no guarantee that it won't come back again in future years, but ASCO was very successful in pointing out that that it wasn't ready for prime time. It wasn't ready for implementation. And, of course, still some things that were disappointing that didn't happen. OAS CAPS is still there. It's going to be there for a long time. I don't expect it to disappear, but it is, of course, causing quite a bit of trouble for many of our surgery centers. I think, Sue, the saddest part about this is that I feel, and I think most of our centers feel, and certainly a lot of our listeners that we've talked to, that it has not resulted in better information. Mm-hmm. We understand why it's being done. We do understand that it is a good way of getting feedback from the patient, but it is so long, it is so complicated. I don't think we're going to get the number of responses we've gotten in the past.
No.
And because it's dictated to us, we aren't able to ask the questions that we want to get from our patients.
Yeah, the things that we're concerned about, the things we know we have the power to change.
Right.
And things that we can implement good interventions for to really improve the patient care.
Right. And to your point, one of the things that we always pride ourselves as part of our quality improvement program is when we identified a problem that required more research from the patient, it gave these surveys, our surveys, when we were doing them or creating them ourselves, allowed us to make a change to it to be able to gather that information, even if it's only for a short period of time. Yeah. And that, unfortunately, is gone now. And I am sad that's happened, but that's something that we can't fight anymore. Mm-hmm. So other things in the news in the last year, the industry really saw a steady increase in the amount of activity from deals such as private equities getting into the marketplace, a lot of consolidation, ASC selling out to large management firms, et cetera. I will point out, though, Sue, one thing that we've seen at Ambulatory Healthcare Strategies is that at the same time that's happening, there are there are surgery centers that are looking to get out of management deals. So, depending upon where you are in that cycle, I've seen over the years people, get into management agreements, and then, after a while they may or may not, be totally happy with it and look into other alternatives. And that's one thing that we have seen in our business is that, a number of times organizations that have been part of a management company have found it necessary to disengage from them, but they still want a lot of the services that come from a management company, and that's, of course, where Ambulatory Healthcare Strategies comes in. Other things going on, one of the biggest stories was the continued and accelerating shift of complex procedures from hospitals into ASCs. And I know we've been talking about this for 50 years, but really has been driven at a much higher rate, I think, now from advancements in technology, various cost savings related to being able to do it in an outpatient setting or in an ASC setting. And then also patient preference for outpatient care. I don't think we really want to be in a hospital if we can avoid it. And our patients want, the more home-like, I don't know if it's home-like, but less clinical atmosphere that you get in the hospital. And we're finding specialties like orthopedics, spine, cardiology, and pain management saw really significant growth. And I think we're going to, if I were to make predictions, which I'm very careful to try to avoid, but I definitely think a safe one is that cardiology is really going to be a major driver of growth in surgery centers over the next 5 to 10 years. And interestingly, studies and reports have highlighted better outcomes and fewer complications for procedures such as total joints and, especially in standalone ASCs compared to hospitals. And other issues that kind of marked 2025 were the continuing rise in operational costs and, of course, problems in the supply chain, as well as staffing constraints. And I think it's fair to say that anesthesia staffing has been probably the biggest issue that we've been dealing with this year. It is interesting, Sue. I haven't heard as much complaints about nurse staffing. I mean, it's still there, but certainly anesthesia has actually usurped that at the top of the list of staffing problems. And then, recent surveys and reports, and even our own reporting on the podcast have shown issues with staff burnout accelerating in the industry, because of the stress that is being put on our staff and the issues that we've mentioned before. ASC leaders have cited these as really major hurdles alongside reimbursement pressures from payers and Medicare. So our costs are going up, but our reimbursement is not, and that's a story as old as time. I think another issue that we've seen accelerating recently is leadership turnover in ASCs. We've dealt with it on the podcast and through our ASC-Central in the form of the bootcamps, where we're realizing that a lot of new nursing leaders, new administrators are coming into the market without totally understanding the responsibilities that they have. And of course, if you're interested in more information about that, visit ASC-Central.com. And then lastly, looking back in 2025, technology integration, such as AI, artificial intelligence and workflows and various tools that are being used in ambulatory surgery centers have been a mixed bag. They've definitely helped improve efficiency and safety, but it doesn't necessarily offset all of the strains that we have on our system. We're going to be introducing actually a year-long series on artificial intelligence to our listeners over the next year. So first one I think will come out sometime late February, early March. So look forward to those where we're going to kind of delve into how AI is transforming ambulatory surgery centers and what we expect the future to be, and just giving you some very practical advice as to how to implement it. Also, competition among accrediting organizations is continuing to accelerate, and the approval of deemed status for DNV in the ASC world brings a fifth player into the accreditation market in ASC. So you might have noted that we've had one episode already in a continuing series on accreditation, and that was with Quad A, with Tom Terranova, who is the CEO there. We also interviewed somebody from ACHC last week, and that interview will be on later this month. And then we also have been talking to HHC. We just haven't actually done the interview yet, so that'll be coming on. We're still working with Joint Commission and DNV to try to see if we can get them on the podcast also, and more to come on that. Sue, why don't you talk a little bit about some recent news, especially that nurses' strike in New York City?
Yeah, as you were talking through that list of changes, few of those kind of pointed to some problems that the nurses have been complaining about. So just 3 years after the previous strike of New York City nurses, close to 15,000 nurses from 3 major hospital systems in New York City, New York Presbyterian, Mount Sinai, and Montefiore systems. And these are all private nonprofit hospitals. And this is the largest nurses strike they've ever seen in New York City. The hospitals are bringing in temporary workers, and of course, this is during a very bad flu season, so it's, a bad time, but at the same time, it's a time when the nurses, I'm sure, are really struggling to get through it, and add that to all the problems getting through COVID that, that was pretty traumatic for many. So these hospitals may also have to cancel procedures or transfer patients or start diverting as the ambulances are coming as they run out of room and staff. The main issues are staffing levels leading to unmanageable workloads, as you had mentioned above, John. It just really leads to burnout, and then of course, as people leave because of that, it just seems to be. I just don't know what the answer is. Other demands include better security in the workplace. There have been a couple of recent violent situations where the police did handle it, but it's gotten a little bit scary. And they want to have, the union asked for a limitation on the use of AI, which was interesting.
Yeah, I think that's an ongoing concern in many different industries, is how AI is taking over decision processes. I think what they're referring to is AI being used like doing pre-op assessments, et cetera.
Yeah, and if the nurse has a disagreement just from her almost intuition, you want to make sure you want to be able to follow your intuition and not be told, no, AI says this, and then you don't feel like you're giving them right care. Right. So I understand that. And, of course, increased pay. From the hospital side, they say that they have improved staffing since the strike in 2023 and that granting all the demands that they're hearing would be much too costly. The nurses and the union are saying the hospitals are constantly trying to cut corners on staffing, even after the earlier strike, and that the top executives, of course, earn millions of dollars, and they prioritize profit, and they have been unwilling to compromise. So when the 2023 strike ended, they had an agreement on raises totaling 19% over 3 years. and some staffing improvements, including the possibility of extra pay if the nurses had to work shorthanded. And the previous nurses' contract did expire on December 31st. Now the union says hospitals are retreating from those guarantees and that they're falling short on other promises. One example they pointed out is the promise to make every effort to stop keeping emergency room patients in hallways while they wait for rooms. But the nurses say they're still having to treat patients lined up in the hallways. That's got to be it is for the patients. We both know firsthand from our moms that it's such an uncomfortable position for a patient to be in. And from the nurses' side, I'm sure it makes it much less efficient and convenient. And you just don't have everything on hand, or if there's a code, trying to get them, make room around it. Montefiore did say they've reduced the time from ER to unit bed by 35% to get there. So you can see it's kind of back and forth and back and forth. Yeah. It's just been such an ongoing thing, and I don't know how this is ever going to resolve, but that's not safe for the patient. All the time when we've gone to emergency rooms lately around here, people are lined up in the hallways, and that's just not safe.
Well, and I'm looking at the impact on ASCs, and I think there's two sides to this. First of all, for those that are experiencing burnout, experiencing heavy caseloads,
come to the ASC.
Come to the ASC.
It's easy, you always say, but there's
and
there are benefits.
There are definitely benefits, but one of the disincentives, of course, is the money. Yeah. And I think the flip side of this is going to be, as hospitals have to pay out more to the nurses, inevitably we're going to have to pay more in order to compete with them. So be interesting to see what the results are of this. And we did report on the strike in 2023, I remember, and the result from that. So we'll do the same here and keep everybody informed. But I think it behooves all of us leaders in ASCs to kind of keep an eye on what's going there, because it could be a real indicator of what our staffing challenges and staffing costs are going to look like in the next year.
And for the patients, getting, as we pull more patients, more procedures from the hospital, we'll take some of that burden off the hospital and leave them for those really serious cases or traumas and things like that. There was just a little thing talking about, what we can really push as the benefits for ASCs, because honestly, when you get to a certain point, I think pay is important, but if you're afraid every time you go into work that you're risking your patient's life, or you're just miserable, then there are a lot of more important things in life too.
Well, and those are the employees we want too. Yes. We don't want the ones that are going to be chasing the best price.
We want an easy, we want to make a lot of money, or we want an easy job. You want people that are going to say, I want to feel like I'm doing a good job.
That's right.
And that I have the ability to do that.
Yeah, not that money isn't important, but if job satisfaction and safety of the patient is important to them, I think they're going to find the ASC environment much more beneficial.
Yeah, and family life balance, all of that.
So as we kick off the new year, now's the perfect time to kind of shift gears from looking back on what happened in 2025 to looking ahead as to what every ASC, and especially the governing body, needs to prioritize, needs to do at the beginning of each year. We're talking about those essential annual activities such as approvals, oversight responsibilities, things that are required under the CMS conditions for coverage, and of course the accreditation organizations.
And just remember, these aren't just a list of check boxes. They're really the foundation that keeps your center compliant, safe, and positioned to thrive with all of the changes and the shifts that we've been seeing. So in our focus segment, we want to do a comprehensive rundown on what governing bodies should be addressing early in the year to get set for a safe and productive year. Let's take a short break for a word from our sponsor, and then we're going to focus on beginning of the year activities.
If you work in the ambulatory surgery center industry, whether you're an administrator, a nursing leader, a medical director, an owner, or part of the clinical or business office team, there's one resource you should be using to stay sharp, stay compliant, and stay ahead. ASC-Central.com. ASC-Central is the premier online hub for ASC education, leadership development, and ongoing professional support. It brings together decades of ASC expertise, practical tools, and industry-leading training programs, all built specifically for the challenges of the ambulatory surgery environment. One of our most popular offerings is our series of leadership bootcamps, the industry's most respected training programs for ASC administrators, directors of nursing, and business office managers. These boot camps are not passive lectures. They are mentored, structured, immersive learning experiences that walk you through every aspect of ASC operations and leadership. And many of our boot camps provide AEU credits for CASC, certified administrators, and IPCH credits for CAIP certified infection control professionals, helping you maintain your credentials while you strengthen your leadership skills. ASC-Central also features a comprehensive collection of on-demand educational programs. These are full-length virtual conferences recorded over the past several years, covering regulatory compliance, quality improvement, credentialing, infection control, finance, governing body education, and much more. These programs are detailed, engaging, and highly practical, and many of them also offer CASC and CAIP continuing education credits. For ongoing access and continued support, ASC-Central offers a range of membership programs. Patron membership, designed for listeners of the ASC Podcast, includes access to regular group Zoom sessions, an extensive resource library, and complimentary access to several key conferences such as the Conditions for Coverage, Medical Director, Credentialing, and Finance and Accounting programs. ASC-Central Premium Access, our most comprehensive membership level, includes everything in the Patron tier, plus full access to all leadership boot camps, private consultations, live and recorded conference access, individualized staff training, and ongoing interaction with leading experts in the ASC industry. So if you're ready to elevate your knowledge, strengthen your team, and gain access to the most complete ASC education platform available, visit asc-central.com or email us at info@ascpodcast.com for more information. ASC Central, where ASC leaders come to learn, grow, and succeed.
So as we begin yet another new year, let's talk about some of those annual things that need to be done in an ASC from a regulatory and accreditation perspective. And as we all know, and as we always talk about here on the podcast, the governing body, whether it's the board of directors or the owners or designated leaders, really hold full responsibility for the ASC operations. And under the CMS conditions for coverage, better known as the Medicare regulations, that's, of course, 42 CFR Parts 416. The governing body is accountable for everything from policies to quality care to a safe environment. And accreditation organizations build on the regulations with more specific expectations. The start of the year is really an ideal time for scheduling those meetings to review and approve annual items, ensuring that you're always survey ready.
So the governing body has to meet at least annually, but expect you'll have to meet more frequently to meet all of the requirements. At least one of your meetings has to cover annual things.
And Sue, this is one of those things that I think most of us do try to have an annual meeting where we cover all of those items, but it doesn't have to be done that way as long as you're doing things on an annual basis.
Yeah.
So some of our centers, for example, take all of the things that have to be done on an annual basis, and they'll spread it through the 4 quarters, which is a very efficient way of doing it. It doesn't make that annual meeting that much longer. And we always know that it's always difficult to get the doctors together to have, maybe I'm making a broad generalization, but let's face it, I think most of our audience out there understands the difficulty it is to get the governing body, the owners, the doctors to meet to talk about these things, which they find confusing or cumbersome to deal with. So if you spread it out over 4 quarters, that can make it a little bit easier to handle.
It kind of depends on how organized you are, because one benefit of doing it all at once is you always know that whatever January or February meeting is going to have all of that information if you have to look back and see that. And if you have trouble getting everybody together, you can make sure this is the one meeting they have to be. But like you said, it can maybe be, you can delve a little more into each part of it if you separate it and really commit one meeting every quarter to part of this.
Yeah, I mean, I think it really is personal preference there. I tend to like to spread it out, but to your point, I totally agree that it's a lot easier to find all of the things if there is one annual meeting, especially when a surveyor comes in. So let's just kind of run down a list of the stuff that needs to be addressed at least annually. We'll start with strategic planning, goals and objectives. You need to have annual goals and objectives. And they should be, things like organizational goals. That's kind of optional, but you do have to have infection control goals, which are required from the infection control risk assessment. You have to have goals and objectives for the quality improvement and safety program. And that comes out of the requirement to have an annual review of your quality improvement program. And then under emergency preparedness, your hazard vulnerability analysis is going to require you to set annual goals and objectives also. So the best thing to do here, I'm a strategic planning guy. I love strategic planning and setting goals and objectives based upon a really comprehensive strategic plan. But that's not really feasible for many organizations, especially small organizations. So at the very least, at the annual meeting, establish some infection control goals, quality improvement goals, and emergency preparedness goals, and you'll be well set for a survey.
And then the annual contract review. So the governing body, in cooperation with the administrator, reviews all of the contracts and certifies that they are in compliance with federal, state, local rules and regulations and accreditation standards.
And that is not an unusual item to have cited during a survey because it is a federal requirement in addition to an accreditation requirement. So next, we should be making sure the governing body regularly reviews federal and state regulatory compliance as well as accreditation requirements. So the governing body should be reviewing the current accreditation standards depending upon your accreditation organizations, any changes to state regulations, any changes to the federal certification requirements, and any recent changes with your staff. Changes in the policies and procedures and processes also have to be implemented to ensure compliance with all the applicable regulations and standards, and then make sure also that the staff have been trained as appropriate.
And you also review all the policies and procedures. So you review the policy and procedure manual in its entirety at least once a year.
Right. And then if you have a tissue bank, make sure your policies and procedures are updated, and again, it's addressed during the governing body meeting.
And the annual review of risk management. The governing body reviews and approves the risk management plan.
After looking back on all the risk management activities during the year. And then, and likewise, an annual review of the safety program. Again, the governing body needs to review and approve the safety program, looking back on all the activities of the quality improvement program or committee with regard to safety.
And you're noticing a trend here. The annual review of emergency preparedness plan. The governing body reviews and approves the emergency preparedness plan and the risk assessment for the year. So you're really setting yourself up of looking back and figuring out, reviewing all of the plans and making your plans moving forward for the year.
Yeah, and we probably should stop here for a second just to remind everybody that you do need to do an annual hazard vulnerability analysis, or HVA, and that becomes the basis for this annual review and the annual changes to the emergency plan. Now, the federal requirements are that the plan be reviewed on a biannual basis. But many of the accreditation organizations do require you to review it on a regular basis or an annual basis. So my recommendation is probably to continue with that annual review if that's what you've been doing in the past. And, of course, the annual review of the infection control plan. As Sue said, you can see the trend here. The governing body needs to review and approve the infection control plan. And much like the emergency preparedness plan, there needs to be an annual infection control risk assessment, or an ICRA, performed each year. And the plan needs to be updated based upon the results of that risk assessment. Now, Sue, one of the things that I see constantly when I am out during a survey is people will fill out the infection control risk assessment and without really making any analysis of it. They'll just fill out the boxes, come up with a score, but they don't do anything with that.
And it could be the same every single year because you're not improving anything.
That's right. And to your point, I've often seen people literally copy the prior years and put the new year on top, which, to your point, indicates that there's been no improvement on the infection control program from the prior year. So you need to take these things seriously. And then again, it has to come to the Quality Improvement Committee and ultimately to the governing body, as we just talked about.
And that's how a lot of the accreditation agencies and different regulations, I guess all of them, make the governing body ultimately responsible for everything. And this is how you show that they are paying attention to it, that they're involved in it. Yeah,
and actually you bring up a very good point, too, is that as we're going through this list, and you mentioned it earlier when you talked about this is not a checklist. And the reason that we've said that is that so often people just check these boxes off every year. They just go to the governing body and say, does everybody approve all these things? I've got to say, you really need to spend a little bit more time looking at it to really have a safe and high-quality environment. You got to take this stuff seriously and really do review it and look for opportunities to improve it.
Yeah, and if you present it or the administrator presents it in the right way, you may not get everybody excited about it, but there are doctors that are going to be interested and excited on, okay, how can we improve this care?
Yeah.
And they really, it just, you have to not make it too long and tedious and boring and really have them feel like you're looking for their opinions.
And actually, thank you for mentioning that, because that brings up another point that I'd make here is that this shouldn't be the administrator just spouting off all these things. I know it's almost like we're demonstrating the wrong way of asking these questions during a board meeting. Mm-hmm. The right way to do it is to say, okay, let's talk a little bit about the infection control program. This is what we found. Does anybody have any other observations or questions or suggestions?
Yeah, and sometimes the doctors will say, well, we had a bunch of people that, whatever. Maybe a lot of the patients I noticed were really at in poorer health, or often you get really good feedback if they're really engaged.
And it's not a one-way conversation.
Yeah.
The annual review of the quality assurance program, whatever you call it, quality improvement program, quality assurance and performance improvement, whatever that is, the governing body needs to review on an annual basis the quality assurance program report. There should be some report that's being generated, or at least some written document that goes to the governing body and reviewed by the governing body and then signed off on. And then based upon that annual review, the governing body approves the next year's quality assurance and performance improvement plan. And as we mentioned earlier, a good thing to do with both what we just talked about before, the infection control plan, and this one, the quality assurance program, is take the goals and objectives out of these plans and put them up above under the strategic plan.
The governing body performs a review of the effectiveness of the quality improvement program based on the annual review of the quality assurance program. Based on this review, you determine whether the QI program is still effective or if any changes are needed.
Yeah, so these are two separate bullets, but they are very much tied together. In some ways, you probably want to do the quality improvement program effectiveness before you do the actual review of the program, and that's just a bullet problem, I think, with our script here. But definitely you want to look back on the year. And Sue, this is another great opportunity. I tell people, especially when I'm a surveyor, is don't be afraid to say, our quality improvement program could have been better. I think as a surveyor, I like to see critical analysis of things, and showing that, we learned so much this year. Perhaps if we do a little bit more of this, or maybe, this part of the program just wasn't very effective because, we've never had any problems in 20 years in this area. Maybe we don't have to keep looking at that anymore. So, critically analyze that program, especially if there's been changes in personnel, because everybody comes in with a different skill set, and lean into that. Hopefully that new person will bring a new perspective, and looking at that quality improvement program might have a different direction or trajectory to go into. On an annual basis, you should also be looking at your facilities and your equipment and just discuss any issues that have been identified throughout the year. One thing that you need to do is make sure that the NFPA 99 risk assessment is updated every year. This is not a document that's redone every year. The NFPA 99 risk assessment starts off actually before your organization even opens to evaluate the type of equipment you have and infrastructure you have to determine what risk abatements or risk management factors need to be taken into consideration. And then on an annual basis, you also want to approve the wet versus dry risk assessment. If your operating rooms or treatment rooms don't have GFCI or line isolation monitoring, so make sure that you do that. That's something certainly surveyors are looking for on an annual basis, and you want to address that in the governing body meeting. And based upon the review, based upon that risk assessment, determine whether it's time to put in an LIM system or a GFCI system.
And this one's very short, the annual review of patient rights. So you just have to review the patient right, Bill of Rights or whatever.
Yeah. So again,
make sure it's appropriate.
So again, look at the patient rights and responsibilities that's hanging, hopefully in your waiting area, and make sure that all the information on it is updated. A couple things that I've noted in it too over the years is they might forget to mention the name or update the name of the person that you should need to contact if there was a complaint. A big thing, we've mentioned this a couple times before, I do want to mention it again, make sure your ombudsman listed in the patient rights and responsibility has been updated based upon the most current guidance from CMS. And then you want to make sure that on an annual basis you appoint or reappoint all of your officers. Now, I do need to point out that there isn't really a CMS requirement that you do this annual appointment, but think about it. If your administrator was appointed 20 years ago, how are you going to show to a surveyor that their current appointment is still in place? You don't want to have to go back through 20 years of minutes to do this. So it really makes your life so much easier when you do an annual appointment. And the other thing is we forget that during the year somebody else was put in that position. So I just wanted to run down a list, and Sue, maybe we'll alternate back and forth here, the list of the various officers or different appointments. And not all of these are going to be applicable. Yeah. And then some of these, there's always those small organizations where the name next to that title is the same all the way down. So, of course, we start with the appointment of the administrator.
And then the clinical manager.
And then the medical director. And if this is an anesthesiologist, you'll have to be specific, specifically separate out the director of surgical services and the anesthesia director.
Then the business office manager.
And the quality assurance and performance improvement coordinator, which is often the administrator or the director of nursing there.
And the infection control coordinator, which should be a licensed clinician, of course.
Yeah, and I guess we probably should mention that again. A good point, Sue, is that CMS requires that person to be a licensed healthcare person, such as an RN, an LPN. It could be an MD. Actually, we have a couple centers where the doctor is the infection control coordinator. And it's always good to remind people that they need to have specific training, infection control oversight.
Not just the one that you do to keep your nurses licensed, because we've been asked that before. This has to be very
And actually, that was just asked this last week. You also want to make sure that you have somebody that is in charge of your education. You don't necessarily have to have somebody appointed as an education coordinator, so I think I'll just kind of mention this as a good idea to include.
Yeah. And the laboratory director.
And that's often going to be your medical director also. Those in some states, it can be a non-physician. And then a pharmacy director. And let's mention under pharmacy director that this is the physician. It's not going to be your pharmacist. Since the pharmacist, since most surgery centers, almost all surgery centers, don't actually have a pharmacy. So it's going to be the physician who you are often purchasing the drugs under, if that's the state. But you're going to have somebody appointed. That is a federal requirement.
And the radiology director, if that's applicable.
A safety officer.
Risk manager.
A compliance officer.
The privacy or security officer.
A medical director, medical records director, or health information systems director, whatever title you give to that individual. And again, this is another CMS requirement here that you have to have somebody that's appointed to be in charge of that area.
And the tissue bank compliance officer.
And again, if that's applicable. And lastly, but certainly not least, the laser safety officer, if it's applicable in your organization. Now, I wanted to go through a couple other items that you may or may not be required. It's all depending upon what your operating agreement or your medical staff bylaws say. You're going to want to address on an annual basis who the governing body is. Usually it's an LLC, the organization's a limited liability company, which requires you either to have a committee of the whole, which would be all of the owners, or to have a board of managers. So make sure that somebody is reading through that operating agreement and making the appropriate decisions, making the appropriate appointments, making the appropriate elections based upon whatever the operating agreement states. This has been a real issue lately, I will say. As a surveyor, when I look at the operating agreement, I often find that the governing body minutes do not actually reflect what the operating agreement says you need to do to operate your governing body. So definitely need to look at it. I love including it in your annual things because that way there's that automatic look back on it. Yeah. And then also you want to look at your medical staff bylaws and review what they say with regard to your medical advisory committee, if that's applicable, or your quality improvement committee. So definitely want to make sure that you're looking back and appointing all the appropriate individuals to these committees as part of that annual agreement. Also, on an annual basis, you need to do a review of your scope of services, or we usually call it an approved procedure list, and the governing body really needs to review that list and make any changes. Now, this is something that's often being revised throughout the year also, but just make sure that there is at least an annual review of the scope of services and approved procedures.
And we have seen times when it just kind of gets missed. You add a minor thing, so you really have to make sure that you're reviewing that very thoroughly.
And you bring up a good point, too, is that remember to tie that into your delineation of privileges. And that's a good time to look at the approved procedure list anytime that you're approving a delineation of privileges for a physician, because you cannot approve privileges to a physician to do a procedure that's not on your approved procedure list.
And your formulary, high alert medication list, and confused drug names used to be the look-alike, sound-alike list. So you want to review, or your governing body will review that and approve the formulary and all of that. And, of course, make sure you have that list someplace.
Posted, yeah.
Yes,
and again,
that's not the total confused drug name list, but specific to your center.
Yeah, and again, this is one of those things that you're probably revising throughout the year, but have some process in place to look at it at least annually. And then USP 800, which we've talked about a little bit. We don't talk about it a lot because it's not that applicable to most surgery centers, but you need to do an annual risk assessment of your hazardous drugs as per USP 800. This is generally something that your pharmacy consultant, if you have one, will do for you, and then you just take it to the governing body. Generally, it's not going to require any intervention on your part. There are very few surgery centers that actually use hazardous drugs. Let's talk about finances for a second. From a financial perspective, you may wish to approve an annual budget. Now, if you've listened to me over the years or have heard me speak, I'm not a big fan of budgets in a surgery center. That doesn't mean that I don't think it's important to have some type of financial oversight or some financial goals. I just find that budgets tend to be very rigid. And so I'm just not a fan of requiring an organization to do a budget, which often becomes irrelevant, the month after you've approved it. But you do have to have some type of plan for financial management, and whatever that oversight includes, make sure you're addressing that in the annual meeting. As I'm thinking about this, Sue, that's probably a good topic for us to talk about in a future episode. So make a note about that. You do have to also do an annual review of the financial statements and the tax return, but they probably won't be ready in time for the first meeting of the board for the year. And then let's also remind everybody about state licensure. Make sure that you're aware of and following any state-specific annual activities that might be required by your state. And lastly, let's not forget about annual training. Now, you don't necessarily have to be doing the annual training at the beginning of the year, but it has to be done annually. So I just wanted to run down a list of the annual education program requirements. In other words, what's generally required. Now, it's going to sound like a comprehensive list, but it isn't necessarily comprehensive. Again, your state might dictate some specific items. And your accreditation organization might dictate some specific items, but these are generally what's included in your annual education program, and also, of course, included in your orientation program. So let's start with, of course, HIPAA. You have to do annual training on the on HIPAA, and then OSHA requires you to do annual training on safety data sheets. OSHA also requires you to have policy and training on operating room safety. OSHA requires you to have workplace violence and aggression training. And, of course, OSHA does require to have a program and training on bloodborne pathogens and sharp safety.
And then have training on personal protective equipment, diversity and inclusion, emergency preparedness, pain management, and, if applicable, malignant hypothermia.
And if you are using radiation devices, you need to have training on radiation safety. If you have lasers in your organization, you have to have training on laser safety. Every organization has to have training on sexual harassment.
You have to have training on human trafficking, child, elder, and domestic abuse, disruptive behavior, impaired, incapacitated healthcare provider.
You have to have training on patient rights and responsibilities, on abbreviations used in your organization, on universal precautions. You have to have training on your timeout process. You have to have training, very comprehensive training on emergency preparedness, and training on what the admission guidelines are for your organization.
And training on Code Blue process, patient transfer policy, adverse incident reporting, patient complaints and grievances, infection control, and pharmacy.
And I did want to go back to that adverse incident reporting. That is one thing that, Sue, I see often again during surveys is that people will forget to do that annual training and incident reporting. And I usually find that out by talking to staff during a survey as to whether they're aware of the incident reporting process. And unfortunately, very frequently they don't. So I know that was a lot to absorb. Luckily, you can listen to it over and over again here. And I hope it's been helpful to you. But this, let's hopefully this will give you a good start for the year. Hopefully your governing body will be interested in at least talking about some of these topics and understand the importance of dealing with that. So let's take a short break. And when we come back, we'll talk about upcoming events.
In this segment, we provide an update on upcoming topics for the podcast, our upcoming virtual conferences, and upcoming speaking engagements for John and his staff, and other events in the ASC industry.
And as we mentioned, we're going to be doing a series of episodes on artificial intelligence that'll kick off sometime in late February. We are continuing our series on the accreditation organizations, and we are still finalizing for ASC-Central the upcoming boot camps this year, as well as a couple other full-day conferences.
So if you're interested in taking the CAIP exam, which is a Certified Ambulatory Infection Preventionist, the next exam period is from March 1st to the 31st. Applications must be submitted by January 31st, and the exam is offered each March and October.
And you go to, so these are exams that you take at a testing center. So that's what happened when you go into the application. You choose a testing center to do that. For more information, go to about CAIP.org. And by the way, we should mention that if you're looking for training on to prepare yourself for the CAIP exam, we have some wonderful training programs over at ASC-Central.com. And the OR Business Management Summit is going to be in Austin, Texas, February 9th through the 11th, 2026. Registration is still open. It will be open actually until the day of the show, but our discount hotel is only going to be available through the 17th. The reason I bring up so much information is I'm very excited about this conference this year. I'm going to be doing a 3-hour pre-conference on finance, and it's actually a workshop. Which I don't often do workshops, so this is going to be exciting for me. So for more information, visit or Google OR Business Management Summit.
And the AAACN, or the American Academy of Ambulatory Care Nursing, is having their annual conference on April 14th through the 17th at the Hilton Orlando in Lake Buena Vista, Florida.
And ASC is combining with SAMBA this year to do an annual conference and expo. It's going to be May 13th through the 16th, 2026 in Washington, D.C. And we're going to be there with our whole team from Ambulatory Healthcare Strategies and from the podcast. And just like in the past, we'll probably do 2 to 3 podcasts where we'll interview people from the conference to get their observations. And I'll be doing a session, and Lori Rodericks will be doing a session there too. My session is going to be on strategic planning, and it will also be a workshop this year, which I've never done with ASCA.
The Gulf States ASC Conference, which includes Alabama, Louisiana, and Mississippi, is June 17th through the 19th, 2026 at the Ritz-Carlton in New Orleans.
And the Florida Society of Ambulatory Surgery Centers, or the FSASC's annual conference and trade show is July 22nd through the 24th at the Hyatt Regency Grand Cypress in Orlando, Florida.
And CASA's annual conference and exhibits is September 2nd through the 4th, 2026 in Monterey, California.
And we will be there most likely also. I don't know that I'll be speaking there this year, but Sue and I love being in Monterey, California. So if we can make it down there, we'll definitely get down there and do an episode from there too. And the Pennsylvania Ambulatory Surgery Association's annual meeting and educational conference is going to be October 4th and 5th, 2026 at the Eden Resort in Lancaster, Pennsylvania.
And the Atlantic States ASC Conference which is North Carolina, South Carolina, and Virginia, is October 8th through the 9th at the Embassy Suites, Raleigh-Durham Research Triangle in Cary, North Carolina.
And the New York State Association of Ambulatory Surgery Centers annual conference is going to be November 17th through the 18th, 2026, with the pre-conference on November 16th at the Desmond in Albany, New York. And we have a very heavy presence there since, of course, it's right down the road from us here in New York. So definitely make sure if you're in New York to attend that. And then visit ASC-Central.com website to see the various conferences that we're going to be having in 2026. Many of those things have not been settled yet, so I'm sorry that we haven't been able to get to it. But again, visit ASC-Central.com for more information. And on-demand versions of the ASC Director of Nursing, the ASC Administrator, and the Business Office Manager's bootcamps are available on our sister website at ASC-Central.com. We do want to keep reminding people about the benefits of becoming a patron member of the podcast. So by becoming a member of the Patron Program, which is available at ASC-Central.com, you can gain access to these usually weekly drop-in sessions where you meet with us through a Zoom session to ask all kinds of questions. Generally, we have 2 to 3 surveyors on in each of those meetings. This last week, I think we had 4. And it's always a great opportunity to connect with other patron members, with other listeners, and with, of course, the team here at ASC Podcast. And we always have a lot of fun talking about recent survey experiences and anything else that's of interest in the to the audience. And by the way, Sue, we often get feedback. As a matter of fact, we asked on Monday's drop-in session some suggestions, and the suggestion was come up that we have an episode on life safety. So that's another item that we're going to have to fit into our already busy schedule now. And the membership in the Patron Program also gives you access to other things such as a database of policies and procedures, forms, et cetera, as well as some of our conferences over the last couple of years. And your support of the Patron Program helps us to maintain and grow the podcast, covering essential costs like research, travel, equipment, and production. To learn more and to become a member, visit ASC-Central.com.
Thank you for tuning in to this episode of the ASC Podcast with John Goehle. We hope you found the discussion insightful. If you did, please share it with your colleagues in the ASC community and be sure to subscribe so you never miss an episode. We appreciate your feedback and any suggestions for future topics. Please reach out anytime at comments@ascpodcast.com.
And a special thank you goes out to our incredible team, our sound editor, Susan Cronkite, executive producer, John Goehle, and our committed research team, Sue Cronkite, Jenna Alvarez, Judy D'Ambrosio, Mike D'Ambrosio, Zach Kalritis, Jim Masters, Stuart Rosenberg, Amy Cronkite, Lori Rodricks, Kathy Foti, Donna Macchio, Christina Norman, and Katie Pearson. Their hard work makes this podcast possible.
Our theme music is by Media Sushi and Mike Noah. The ASC Podcast with John Goehle is hosted on Podbean and can be found on all major podcast platforms. Thank you for listening, and please join us in the next episode. This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, RFX Solutions, MedServ, and Ambulatory Healthcare Strategies. Surgical Information Systems provides cutting-edge information solutions for surgery providers. RFX Solutions is your all-in-one healthcare regulatory compliance software. MedServ, which offers the only digital narcotics cabinet specifically designed and priced for surgery centers, helping develop standardized processes and compliance, eliminate paper logs, and prevent drug diversion. And Ambulatory Healthcare Strategies is the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, visit our website at ascpodcast.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.